دكتور لبنى معانا؟
نبدأ هسي؟
أي تفضل يا دكتور لبنى، تفضلي. مرحبا بك يا دكتورة.
مساء الخير، أنا لبنى صديق. مساء الخير بروف عماد، مساء الخير دكتور خديجة. Tonight إن شاء الله we will start our hematology triology series. الطبابة Advanced Training Center invites you to the first session under the title of Peripheral T-cell Lymphoma by Dr. Khadega Abuelgasim, MBBS, University of Khartoum, Internal Medicine Residency and Hematology Oncology Fellowship Program at Howard University Hospital, Washington, District of Columbia, American Boards of Internal Medicine, Hematology and Medical Oncology, Consultant Hematologist at King Abdulaziz Medical City, Ministry of National Guard, Health Affairs, Riyadh, Associate Professor at King Saud ibn Abdulaziz University of Health Sciences, has many published scientific papers in the field of hematology. Our objectives for tonight, one, peripheral T-cell lymphoma, PTCL epidemiology, clinically significant PTCL updates in 2016 WHO classification, prognosis of PTCL, different induction regimens, role of upfront HSCT consolidation, upfront auto versus allo SCT in PTCL, maintenance strategies, moving new therapies upfront. دكتورة خديجة تفضلي.
السلام عليكم ورحمة الله وبركاته. I would like to start with thanking Dr. Imad Hassan, Dr. Taysir, and Dr. Lubna and all the Tababa group for inviting me to give you this talk tonight. And I hope that we will have a fruitful hour, inshallah. So peripheral T-cell lymphoma is a rare type of lymphoma, but at the same time, it's very challenging. So in the field of lymphoma, most people know about Hodgkin and non-Hodgkin diffuse large B-cell lymphoma, but very few people are experts in treating T-cell lymphoma because of its rarity as well as because of its lack of response to traditional therapies that we know of. So I chose to talk about the induction therapy, treatment of newly coming T-cell lymphoma cases. If you want to talk about relapse or refractory cases, that's a different ball game, and you need to probably an hour or so to talk about that. So like Dr. Lubna mentioned, the outlines of my talk tonight will be, just trying to advance my slides, 1 second. Already, I hope you're seeing my slide now. We'll talk, briefly about the epidemiology of peripheral T-cell lymphomas in the world as well as in the Middle East, and whatever I could find in the literature about the epidemiology of lymphoma in general in Sudan. We'll talk briefly about the updates regarding peripheral T-cell lymphoma in the revision of WHO classification of hematological malignancies that was published in 2016. Talk briefly about the prognosis of peripheral T-cell lymphoma. We'll talk about, again, induction regimens and the role of hematopoietic stem cell transplant in consolidation of these patients. We'll talk about the comparison studies that compared allo to autologous stem cell transplant, and then more recently, maintenance strategies after stem cell transplant. And I'll talk about, if we have time at the second half of the talk, about the new novel agents that were proved to be effective in relapse setting, and if you bring them up front, are they worth the try? So first, I'm starting with this particular slide, just because that I found the studies published online about lymphoma in Sudan are coming either from Khartoum or Madani. So it seems like these are the most dense areas in Sudan, and I hope that studies that are published are reflective of the true epidemiology of lymphoma in Sudan. So I found this study from the cancer registry about the...
احنا بس السلايدز ما ظاهرة يا دكتورة خديجة. If you can share your slides بس احنا عملنا.
Okay. One more time.
ومع الشير سكرين هاي تحت.
So how about now?
ممتاز كده تمام.
Okay, you see it full screen دكتور عماد؟
ايوه هي بس enable editing لانه مكتوب enable editing فوق. ايوه. ايوه.
Okay.
ايوه بس تمام بس
Okay,
ايوه كده ممتاز.
Okay, so should we start over or?
ايوه تفضل ايوه لا ستارت اوفر احسن عشان نبقى معك في نفس الخط.
طيب تمام. Already. السلام عليكم ورحمة الله وبركاته. I would like to start with thanking the Tababa group for inviting me to talk to you tonight, and I hope that we will have a fruitful hour. We're going to be talking about peripheral T-cell lymphoma, a rare type of lymphoma, but very challenging. And in this talk, we focus mainly on upfront therapy for this type of lymphoma. We're not going to be talking about any relapse or refractory disease because that's a different ball game, and probably we need to dedicate another whole hour for that. So we'll talk about the frontline therapy, and we'll start with some epidemiology and prognostication like Dr. Lubna mentioned earlier. So these are the outlines of my talk. I'll talk about the epidemiology of peripheral T-cell lymphoma worldwide, in the Middle East, and whatever I could find in the literature about the epidemiology of lymphoma in Sudan. I'll talk about the clinically significant updates in the revision of the fourth and latest WHO classification that was published in Blood in 2016, pertinent to peripheral T-cell lymphoma. Talk briefly about how to prognosticate peripheral T-cell lymphoma, what are the most commonly used or the approved peripheral T-cell lymphoma induction regimens. We're going to talk about the role of transplant consolidation. We'll compare between the outcome of allogeneic versus autologous stem cell transplant, this patient's population. And more recently, there are maintenance strategies or consolidation strategies after induction and after transplant for these kind of patients. If we find time at the end of this talk, we'll talk about how we move the new therapies, the non-approved kind of investigational drugs upfront to the front line after they're approved or proven of benefit in the relapse refractory setting. Okay, so I'll start my talk with this slide, and actually I thought this is important because most of the papers that are published are coming either from Khartoum or Wad Madani, and I think these are the most dense areas. So hopefully whatever epidemiological studies that are published are representative of the true epidemiology of lymphoma in Sudan. So this particular study by Dr. Intisar from the Cancer Registry was 2010, and it shows here that lymphoma represents around 7% of the newly diagnosed cancers in Sudan. Again, I think this is typical to what is seen in the Middle East in general, similar to what you see in the world. However, you see here in this, as if there are no men affected with lymphoma, which tells you that maybe they're not actually very accurate estimates. But however, this is what we found. Already, another study showed also, this is from Wad Madani, from the National Cancer Institute, Jamiat al-Jazeera, and it shows also lymphoma as 7% of the newly diagnosed cases. And I think this is a good chunk, and I think it needs to be taken care of. And this is compared to the population of Sudan and compared to the new cancer cases, 7% is significant. Alright, another study that was published in 2014, from the Jamiat al-Khartoum, they actually described a total of 62 cases of lymphomas, and T-cell lymphoma represented less than 1/6 of the lymphomas, which again is similar to what is published in the Middle East, North America, and North America, as well as Asia. That's different, of course, if you compare South America, for example, on the Far East, and that where you find T-cell lymphoma more common than B-cell lymphoma, and that's related to viral epidemiology, more common HTLV infection in those areas. Regarding the subtypes of T-cell lymphomas, peripheral T-cell lymphoma, none otherwise specified, is by far the most common lymphoma worldwide, followed by the anaplastic large cell lymphoma and angioimmunoblastic T-cell lymphoma. One exception is Asia, where you find NK T-cell lymphomas as common as peripheral T-cell lymphoma, NOS, and you find most of the data about this particular disease entity coming from Japan, most of the studies, because it's just common there. In the Middle East, the difference is that ALK positive anaplastic large cell lymphoma is a bit more than other areas in the world. So for the purpose of this talk, we're gonna be talking about nodal T-cell lymphomas because they're common. They share similar clinical presentation. We generally treat them the same. If you want to talk about cutaneous T-cell lymphoma, that's a different ball game. Also extranodal, not as common, very aggressive, and then they are treated differently. So we're not going to be talking about them in this particular talk. Most of the studies include peripheral T-cell lymphoma, angioimmunoblastic, and anaplastic large cell lymphoma, whether it's ALK positive or ALK negative. So in the WHO classification revision that was published in 2016, some of the changes that were pertinent to peripheral T-cell lymphoma was that anaplastic large cell lymphoma, ALK negative, was a provisional entity. In the past, now is a definitive entity. There are 3 more provisional entities that were added, and there were some molecular subclassification for the anaplastic large cell lymphoma, ALK negative. So one of these, before I move from this slide, DUSP22 IRF on the short arm of chromosome 6, actually one is, this particular mutation is found in anaplastic large cell lymphoma, ALK negative, then the disease tends to behave as good as ALK positive. Therefore, you don't use consolidative auto-transplant upfront. You use it only upon relapse. Some of the entities that are provisionally added were the T-cell lymphoma of T follicular helper subtype, and the follicular T-cell lymphoma, the breast implant associated anaplastic large cell lymphoma, which is ALK negative by definition. So these are new provisional entities, and most likely they're going to become definitive entities in the future. So these are worth mentioning. Some of the prognosticating indices that are used for peripheral T-cell lymphoma are the International T-cell Lymphoma Project, which has the age, performance status, and platelet count. And that's actually relatively old, so people are not using it as often now. The peripheral T-cell lymphoma, the International Prognostic Index also. This is what we use in diffuse large B-cell lymphoma, for example, aggressive B-cell lymphomas, which the acronym APPLES. And actually this was tested in a group of 126 T-cell lymphoma, and it was found to be prognostic. So now this is what we use for peripheral T-cell lymphoma. Some people use the PIT, which is prognostic index for peripheral T-cell lymphoma. And this is, a bit old, but again, similar parameters, except for the bone marrow involvement and Ka-67, which is used as an additional marker for poor outcome. So we know that IPI is prognostic because it was studied and it was found that patients with low IPI, they tend to do a lot better than patients with high IPI. Okay, so again, in terms of progression, event-free survival and progression-free survival. But to be honest with you, most of the T-cell lymphomas are aggressive. Some of them are more aggressive than the others. We'll come to see that in a minute. And most of the studies actually are coming from the German high-grade non-Hodgkin lymphoma study group. Okay, the same group looked at the outcome of different types of lymphoma, and you see here with the green curve, anaplastic large cell lymphoma, ALK positive, excellent event-free survival, excellent progression-free survival, and overall survival. Therefore, these patients, we don't transplant them up front. And then again, later now we came to know that thus mutated ALK negative do the same. If you see here, angioimmunoplastic and peripheral T-cell lymphoma, they all do bad. I mean, if you lump NK cell and all the other, hepatosplenic and the others, the outcome is much worse, the very rare subtypes. Again, the IPI, when it's lumped with the type of lymphoma, it makes a huge difference. Actually, if you see here anaplastic large cell lymphoma, ALK positive, with high IPI, 33% of them are alive at 5 years, while if they have low IPI, 90% of them are alive. If you look down here for hepatosplenic and enteropathy associated, these are very bad. So none of the patients are alive if they have high IPI at diagnosis. Again, we're concerned about the top ones here. So again, about 1/3 of the high IPI patients are alive at 5 years, even less with peripheral T-cell lymphoma NOS. The treatment outcome of peripheral T-cell lymphoma has been disappointing up until recently. So I'll start with the CHOP era, and then after the incorporation of other new therapies, things have changed. So previously, when this paper was published, at least with the CHOP era, anaplastic large cell lymphoma, did better than other aggressive lymphomas, but overall, only 1/3 of T-cell lymphoma patients are alive long-term. So this is really bad. And this is what we get with CHOP therapy. Overall response rate might be okay in some studies, but again, the CR rates are not the best. And 1/3 of the patients are alive long-term with CHOP alone. Except here, when you see when you introduce autologous stem cell transplant as consolidation, then things change. We'll see that in details in the coming slides. Okay, so why do we settle to CHOP if people are doing that bad? So scientists have tried to introduce other therapies to improve the outcome of these patients. One of the first introduction was the addition of etoposide to the backbone of CHOP. And that was done by the German group non-Hodgkin lymphoma study group. And in 7 studies they've done separately, they analyzed them, and they found that the addition of etoposide actually have improved the outcome of patients younger than age 60, especially those of anaplastic large cell lymphoma, especially ALK positive. So huge difference, statistically significant difference when etoposide is added for those younger patients. The overall survival as well has improved. And like I said, for all subtypes, major subtypes, but mostly for anaplastic large cell lymphoma. For elderly, addition of etoposide had led to more toxicity, therefore affected the overall survival. Again, for this particular 7 studies, the biggest was the non-Hodgkin lymphoma B1 trial, and you can see how you can compare the two-whip 6 cycles compared to the CHOP only. Again, for anaplastic large cell lymphoma, huge difference when etoposide is added compared to the other subtypes. Okay, so another indirect way of comparing CHOP to CHUIP, and actually, it's impossible to compare a study to the study, because each study has this different inclusion criteria, different methodology, different way of statistical analysis, but at least you can get a clue of which regimen or which protocol had done better. So when CHOP was followed by autologous stem cell transplant by Remir et al., the outcome improved dramatically with better overall survival and 3-year overall survival of 43%, 6%, progression-free survival of 53%. So this is compared to CHOP alone, much improved. And I want you to take these graphs in as a background when you look at the Nordic study, when actually they used an induction of CHOP for a total of 6 cycles, followed that by autologous stem cell transplant. So now we see the graphs actually are a lot better. Keep in mind, excuse me, keep in mind that they excluded anaplastic large cell lymphoma, while Renier et al., they included anaplastic large cell lymphoma. We know that anaplastic large cell lymphoma, ALK positive, they do better. So if you exclude those patients, you expect the curves to be much lower. But even though they excluded these patients, the outcome was much better with 6 cycles followed by autologous stem cell transplant. So this is now the standard of care in many centers, including the center where I practice. We give CHOP times 6. Again, remember, for patients younger than age 60. Anybody who is above age 60, the toxicity is more, and then there is no improvement in overall survival. Again, they actually presented the sub-analysis of the patients here. So ALK negative is a traditionally bad lymphoma. However, with this particular protocol, their outcome improved dramatically, but the improvement is across the board. Again, remember, keep in mind that they excluded ALK positive anaplastic large cell lymphoma. Another way of improving on the backbone of CHOP by adding etoposide in a different way is using dose-adjusted R-epoch. Now, many of you know dose-adjusted R-epoch is now, you know, the standard, for example, for primary mediastinal diffuse large B-cell lymphoma and for high-grade B-cell lymphoma. So it's used, it was used also for peripheral T-cell lymphoma in 2 trials, actually, with not too many of patients, but because of the bad outcome with CHOP alone, those adjusted EBOC had made it to the NCCN guidelines. So although the studies were phase 2 only, and there were 2 studies with few number of patients, but because of lack of other alternative effective therapies, this particular protocol is there. So in this particular study, those adjusted R-epoch was tested in 41 patients with relatively short follow-up period, but the progression-free survival was 62% and overall survival 82%. Keep in mind that, you know, the graphs with CHOP alone were extremely bad, and there is no stem cell transplant included in this study. So again, this phase 2, and the overall survival is greater, much greater than the previous studies. And then for the angioimmunoplastic, they did a lot better than the peripheral T-cell lymphoma. So it seems that R-epoch is a reasonable regimen when you have angioimmunoblastic T-cell lymphoma. Again, the other study that tested dose-adjusted epoch was also a small study, and it was only for anaplastic large cell lymphoma. Remember, anaplastic large cell lymphoma, especially ALK positive, they do extremely well. Again, the number of patients was very small, and the follow-up, however, was very long, and the overall survival was excellent. Whether it's because of those adjusted R-epoch or the fact that they are mostly ALK positive, you don't know. Again, this particular protocol had made it to the guidelines. Okay, so they compared the ALK positive and ALK negative, and it seems to me that the ALK negative have the curve actually rose, and it's almost close to the ALK positive curve. So again, this is another valid regimen for such patients. I think the state of the art now is adding novel targeted therapy, brontuximab vedotin, and I'm sure most of you have heard of brontuximab vedotin is an antibody drug conjugate directed to the CD30 cluster of differentiation surface antigen. So was approved initially for for classical Hodgkin lymphoma, but and also later with anaplastic large cell lymphoma, but now it's for all CD30 positive lymphomas, including T-cell lymphomas. So before we talk about the inclusion of brontuximab vedotin in T-cell lymphoma, we need to know what's the percentage of expression of CD30 before we can use such targeted therapy in this particular disease. So anaplastic large cell lymphoma, well, whether it's ALK negative or ALK positive, 100% expression. And expression is anything more than 5%. Actually, they express it more than 50%, 100% of the cases. Enteropathy associated 0%, peripheral T-cell lymphoma, 69%. So you need to identify if your patient has CD30 positivity before you introduce this particular regimen. And a very important study is the echelon 2. You know, the echelon 1 was using brontuximab vedotin with AVD in Hodgkin lymphoma. So echelon 2 was using brontuximab vedotin with CHEP backbone in T-cell lymphoma. So you know, brontuximab vedotin causes neuropathy, vincristine causes neuropathy. So whenever you use brontuximab, you should omit vincristine, and this is what they had done in this particular study. So most of the cases, around 75% of the cases were anaplastic large cell lymphoma because of the fact that they you know, because of the fact that they are CD30 positive, so they added brontuximab to the CHIP in a 21-day cycle and compared directly head-to-head with CHOP. So fair and square, they included a total of almost 450 patients. And the progression-free survival have improved dramatically, significantly, with the addition of exchanging vincristine to brontuximab. Again, also the improvement in overall survival with manageable toxicity. The only thing that you have to do when you use brontuximab instead of vincristine is you add filgrastim because of the increased risk of neutropenia and febrile neutropenia. So this particular study had made, you know, a huge landmark for the treatment of T-cell lymphoma in general and anaplastic large cell lymphoma more. And actually in ASH of last year, subgroup analysis of this particular patient who were included in this study, and they received consolidative autologous stem cell transplant off of study. So they're you know, their doctors decided to consolidate them with auto transplant, and that actually led to much improved outcome. Progression-free survival not reached versus 52.6 months. So this is really, for T-cell lymphoma expert, is a big plus. This study has not yet been published. I looked at 2 days ago. Again, even the anaplastic large cell lymphoma who an ALK negative who got transplanted did better, but even non-anaplastic large cell lymphoma, the outcome improved. Progression-free survival not reached versus 33%. So I think this is going to become the standard of care for patients with T-cell lymphoma patients CD30 positive. Again, this is a comparison just to explain whatever I have just said. Brontuximab CHIP frontline for autologous, for peripheral T-cell lymphoma. Alrighty, so what else? You know, what other regimens that are approved out there besides adding to the CHOP backbone? There are other alternative, you know, high dose chemos that were tested and they are approved. One of them is the Newcastle regimen, which we're going to be talking about next. This particular regimen was tested only in enteropathy associated T-cell lymphoma, and that led to improved outcome. This particular lymphoma it's not nodal lymphoma, it's extranodal, it's very aggressive. I've seen 2 cases in my life. Both of them died because of their disease. Very rare, however, very aggressive. So this particular regimen, CHOP, followed by IVE and MTX, followed by autologous stem cell transplant, tested in Newcastle in 26 enteropathy-associated peripheral T-cell lymphoma, peripheral T-cell lymphoma, enteropathy-associated T-cell lymphoma, and the outcome was great. So I think this is a reasonable regimen that you can consider for such a rare entity when you have it. So again, it was one-arm study. So what they did is they compared the outcome to their historical control, the patients with the same disease entity treated with the traditional CHOP, and you can see the difference in the curve. So I would consider Newcastle regimen for somebody who has enteropathy-associated peripheral T-cell lymphoma. What else? Doctors had tried hyper-CVAD. Hyper-CVAD is the drug, is a regimen that MD Anderson pioneered for ALL and Burkitt's lymphoma and lymphoblastic lymphoma. Some centers that use it for high-grade B-cell lymphoma, including the center where I practice. So they said maybe, okay, because it's aggressive, let's try it in T-cell lymphoma, maybe patients will do better. And actually, they did not try it, they retrospectively analyzed the outcome of their patient treated with CHOP versus hyper-CVAD. And this particular study included 135 patients with peripheral T-cell lymphoma. And the overall survival was 46 months. 3-year overall survival was 56% with hyper-CVAD, 62% for CHOP. And I'm surprised that, actually their outcome was great compared to the ones that we looked at earlier from the high-grade lymphoma group. So 66, definitely the overall survival is better with CHOP compared to hyper-CVAD. And when anaplastic large cell lymphoma was excluded, actually the overall survival was 49% for hyper-CVAD and 43% for CHOP. So, increased toxicity, not improved outcome with hyper-CVAD, but still, if you go to NCCN guidelines, you will find hyper-CVAD sitting there. So I would recommend it. Again, there was a study that was presented in ICML in Lugano of 2019, where recently an Australian group tried hyper-CVAD in 26 peripheral T-cell lymphoma and 37 diffuse large B-cell lymphoma with a median follow-up of 30 months. Again, the CR rates were 46%, which is similar to what's reported with CHOP-like regimen. So again, significant toxicity, not improved outcome, not something that I would recommend. Okay, so now we'll talk about upfront stem cell transplant consolidation, and this is something that we don't have yet in Sudan. Hopefully in the future, patients will have access to it. Again, is stem cell transplant. As we know, for lymphoma in general, we don't use it as frontline, usually when patients relapse. But peripheral T-cell lymphoma, just because we know the outcome is bad, only 1/3 of the patients with chemo alone are alive long-term. That's why people why not consolidate them when you can, instead of waiting for them to relapse and then they don't do well. So now it's becoming the standard of care. We talked about consolidation after CHOP in Remier et al. We talked about consolidation after CHUIP. In the Nordic study, we saw the outcome improved dramatically for peripheral T-cell lymphoma. And we know that patients with relapse after auto, patients go to allogeneic stem cell transplant. So now I'm gonna talk to you about comparing upfront allogeneic versus autologous stem cell transplant as consolidation post-induction chemotherapy. So we looked at this area. Remember when I tried to compare CHOP indirectly to CHUIP, we talked about CHOP followed by auto transplant. The 3 overall survival was 48%. When the Nordic group used CHUIP, the outcome improved dramatically, despite the fact that they excluded the good ones, the ALK-positive anaplastic large cell lymphoma. Still, the outcome was excellent. So comparing allogeneic versus auto transplant upfront. This is really important. So there are two studies actually that did that. One of them was indirect comparison and the other one was head-to-head. So this is the first study. It's a phase 2 study where patients younger than age 60 were treated with CHOP ×2 and what they called hypertidum ×2, followed by autologous versus allogeneic based on donor availability. And again, the weird thing about this study, actually, they did not actually, when they presented their data, they presented the whole group that got transplanted. So you cannot really tell if auto is better than allo in this particular study. It was not designed to compare the two. And the patients older than age 60, they gave them a different regimen. They add alemtuzumab, and later on they found that alemtuzumab, which is Campath, and anti-CD52 and monoclonal antibody actually had led to more toxicity rather than improvement in the outcome of patients older than age 60. So again, you cannot truly, find out if allo is better than auto in this particular study. Again, these are patients older than age 60, and it seems like if you get the T-cell lymphoma and you're older than 60, then this is no good. Okay, the most strong study that compared allogeneic versus autologous stem cell transplant frontline as consolidation after chemo was the AATT trial. Now, this trial was presented as an abstract in multiple hematological meetings. One I attended was in Lugano, June of 2019. And what they did here, they used CHOP. Since now we know from the Nordic study, we know from the high lymphoma group, 7 studies that CHOP is better than CHOP. They used CHOP as a backbone, a total of 4 cycles, and based on donor availability, patients either received BEAM as conditioning regimen and went to autologous stem cell transplant, or if they have a donor, they received fludarabine, busulfan, cyclophosphamide, followed by allogeneic stem cell transplant. After actually both arms received DHAP after CHOP. So for Nordic, remember we received, patients received 6 CHOP followed by autologous stem cell transplant. But now they gave 4 CHOP and 1 DHAP, followed by either auto or allo based on donor availability. So again, regarding the patient, the total number of patients was 140. They included ALK negative, not ALK positive, because we know that ALK negative, we no longer use a transplant frontline. And then in the future, people now they'll start saying that ALK negative with DUSP mutation, they don't go for transplant. So things are evolving all the time. So most of the patients will prefer T-cell lymphoma, angioimmunoblastic, and anaplastic large cell lymphoma. They included some of the rare ones like enteropathy-associated hepatosplenic and subcutaneous T-cell lymphoma. So actually, they planned to recruit 140 patients, but the data safety monitoring committee stopped accrual because of they've reached the conclusion. We'll see what the conclusion is before they reach the 140. So why to include more patients? So they stopped after 104 patients. And actually what they found is the event-free survival with auto, the 3-year event-free survival was, auto was 61% with allo 65%. So a little bit of better event-free survival, but not statistically significant. And then this is the patients, 67 patients who got transplanted with a follow-up period of 42 months. Okay, so the overall survival, however, actually the auto did better than the allogeneic stem cell transplant, 70% compared to 57%. So disease control may be a little bit better with allogeneic given the graft versus tumor effect, but because of the side effects of the conditioning regimen as well as the graft versus host disease, the non-transplant, the transplant mortality actually flipped the coin here, and then allogeneic turn out to be worse than autologous stem cell transplant. So I think that was a landmark study, and people now, nobody talks, I think, about, although it's not yet published, but people are not talking about doing allogeneic stem cell transplant upfront. Okay, so now we'll talk about different strategies trying to improve the outcome of peripheral T-cell lymphoma patients. One of these strategies is giving maintenance things. After you treat them, you give them maintenance, whether after autologous or after chemo. It's again an abstract that was published that was presented in ASH of last year. So I didn't get the chance to look at the abstracts of this ASH. They were just made available, I think, yesterday or today. So in this particular phase 2 trial, they used CHEP plus BV times 6, and in responding patients, they either gave them brontuximab for a total of 10 cycles, or they transplant them and then give them brontuximab for up to 10 cycles, similar to what we do with Hodgkin lymphoma. We transplant and we give high-risk patients up to a total of 16 cycles of BV, brontuximab. So their primary endpoint was safety and CR rate, and then the secondary endpoints were progression-free survival and overall survival. So the total number of cases was not many, and the patients at the time of reporting, only 20 patients completed CHEP BV. 10 proceeded to auto transplant, and after only 3 cycles of CHEP BV, the overall response rate was 100%, 58% CR rates, and at completion, the overall response rate was 95%. CR improved from 58% to 90%. So this looks promising, and I think people now are changing the therapy of peripheral T-cell lymphoma. Okay, so now another study that talked about maintenance. Romidepsin is approved for relapsed or refractory peripheral T-cell lymphoma as an HDAC inhibitor, and now people say, okay, why not do transplant, high-dose chemotherapy, do transplant, and follow that by romidepsin. And so this particular study showed the desired 2-year progression-free survival was 70%, and the estimated 2-year progression-free survival was 49%. So to me, this is not very convincing. So I think I would go with brontuximab rather. Minimal toxicity and improved outcome. So now, since we still have time, I'm going to talk to you about novel therapies that were tried, not necessarily made it to the real, real life or, real world, but at least clinicians had tried to do some stuff to improve the outcome. So some of the things that was tried is adding alemtuzumab to CHOP. I think in ClinB, we talked about they added alemtuzumab to patients older than age 60. So this particular study is actually kind of the preliminary data was presented or partially published. The concept trial tested denoloukin TIVT-tox plus CHOP, and actually also partially published. Bortezomib plus CHOP, another phase 2 trial, also published partially, but not with impressive outcome. Aurora kinase, actually questionable outcome when it's added to CHOP. And it was actually stopped in the relapsed refractory setting because of no improved outcome. People are trying to add to CHOP. HUMAC, CD4, belinostat, romidepsin, and chidamide, all HDAC inhibitors that are approved for, second line for relapse or refractory. So people are bringing them up front, testing them in addition to a backbone of CHOP. Some of the studies are still ongoing. We haven't seen their results yet. But with chidamide, actually, there's some published data of one phase 1B study. And then this particular interesting regimen, very aggressive, I'll go over one slide of that. So when alemtuzumab was added in CHOP in Act 2 study, there was just increased toxicity, increased risk of EBV and CMV infection. You know, alemtuzumab is anti-CD52. So it makes people like AIDS, it's worse than purine analog. So makes patients very susceptible to infections, and that's it's not good. Denoloukin diphthitox, actually the overall response rate was not better than CHOP by all means, and there was a short follow-up. So again, it didn't make it. So people tried in 2013, but the pharmaceutical care companies were not impressed. So nobody invested in taking this to, you know, phase 3 clinical trials. So I stopped there. Bortezomib was actually, to me, it was a bit convincing. But again, it, you know, I think that I think Novartis had invested more in the myeloma field rather than continue with the T-cell lymphoma. Because the outcome, the overall response was 76%. Again, it's not much different compared to CHOP alone. So so it didn't make it. Chidamide, however, I thought it was good. The studies that were at least partially published showed some promising improved outcome, and that's why there's some studies are still being done with this particular combination of this HDAC inhibitor. This was presented in ASH of last year, but the short follow-up period. Now people are thinking broadly, why not CHOP instead of just CHOP? Since we know that CHOP is better than CHOP, why not CHOP and add chidamide to it? So here, overall response was not actually great, 73.2%. And in 1 year, again, short follow-up period. But I said it's effective and feasible, novel. Why would I add chidamide myself? I wouldn't. I don't have it, of course, but again, I think CHOP is good enough, especially if you follow it with consolidative autologous stem cell transplant. This also was presented in ASH of last year, very complicated regimen for newly diagnosed peripheral T-cell lymphoma. Again, overall response, despite the fact that you had GDP and IF and all, overall response rate is 73.5%. Again, people are trying to improve on the outcome of these patients with different regimens. Maybe one of them will be better than CHOP or CHEP-B brontuximab. So I think maybe I've given you too much of data here. So I tried to put some summary slides to what I think is, you know, important for this particular disease entity. Consolidative auto transplant for patients who can tolerate it, patients with good performance status, whom their age and organ function allows autologous stem cell transplant have improved outcome of these patients. So whenever it's feasible, I think we should go for it. Even if we can't do it, we can refer our patients to centers that can do it. CHOP, I've shown you retrospectively better than CHOP, especially for anaplastic large cell lymphoma. Again, CHOP followed by auto, better than CHOP followed by auto. And this is in patients younger than age 60. And I've shown you the Remeyer et al. Nordic study. And, you know, even if you look at AATT trial where they compare CHOP and auto, then, or CHOP followed by DHAP by allo, actually CHOP followed by auto did it very well. So I think that would be my way to go, CHOP followed by auto. Brontuximab plus CHIP, exchanging vincristine with brontuximab, better than CHOP. So whenever you have anaplastic large cell lymphoma ALK negative, I would go for that, followed by autologous stem cell transplant, although echelon-2 was not powered and was not designed to test the consolidative auto transplant, but we've seen that the subgroup analysis of patients who have, you know, who underwent autologous stem cell transplant did extremely well. So that would be my way to go for CD30 positive. You know, T-cell lymphomas in general, mostly anaplastic large cell lymphoma, ALK negative. We talked about auto versus allo. Allogenic stem cell transplant has no place in frontline therapy of peripheral T-cell lymphoma because of the toxicity related to the transplant itself. So the tumor control is counterbalanced by transplant-associated morbidities. Again, we talked about the subgroup analysis of echelon 2, not yet published officially, but again, brentuximab chip followed by auto, better progression-free survival. Remember, we talked about comparing CHOP to CHUIP, but nobody compared CHUIP to brentuximab chip. Which one is better? I think we need a study, that compare these two, because both look good. Reasonable toxicities, especially in patients younger than age 60. So I think a study that comparing, CHUIP versus brentuximab chip is needed. But for now, both are available to you. Autologous stem cell transplant post CHUIP is well known after the Nordic study, but after yet to be proved after brentuximab chip. So what about BV consolidation post-auto transplant? Do you think it's going to be better? I think it will probably be better, just like we saw it with Athera trial, for example, in Hodgkin lymphoma. For myeloma, for example, after transplant, we give them maintenance. Now people in AML talking about azacitidine maintenance for high-risk AML patients. So maintenance after transplant, I think is something that will make it to the real world sometime. But anyway, the peripheral T-cell lymphoma patients, especially with high IPI, their outcome is not the best, especially the enteropathy associated and the others other than ALK positive anaplastic large cell lymphoma. That's why people need to continue finding better therapies for these patients. And with that, I conclude, and I would like to thank you all for listening, and I'll take any questions.
I don't know whether Dr. Lubna. Well, thank you much, Dr. Khadija. I'm not sure whether Dr. Lubna is still with us there. Very technical, very high-level talk. I'm sure some people enjoyed, this expert, information, high-level information. If I may ask just one question, is it, from your talk, it looks like it's a bad disease, okay, and maybe one reason is the late diagnosis, right? But is it possible to diagnose it early or to prevent it at all?
Preventing lymphoma is not something that I think people have reached yet. But again, lymphoma is not very common. So people invest in, screening for the common things like breast cancer, lung cancer, smokers, prostate cancer. But unfortunately for lymphoma, because it's rare, you cannot possibly, screen for it. And unfortunately, especially T-cell lymphoma, and even in a tertiary center, many patients come in with vague symptoms, and the biopsies sometimes are also, unless you have a lymphoma specialized hematopathologist, sometimes even our own hematopathologists are, it's not like clear-cut like diffuse large B-cell lymphoma, for example. Some T-cell lymphoma present with hemophagocytosis. Some of them come in with paraneoplastic syndromes. They're not easy to present. Many of them come in with bone marrow involvement rather than bulk lymph nodes that you can see or the patient himself can notice. So, and actually these T-cell lymphomas, when they're diagnosed in early stage with low IPI, usually they do better. You don't even have to transplant them upfront. You just give them chemotherapy or combine chemoradiation. But unfortunately, it's a very tricky lymphoma. And actually, when I decided to do this talk, and I wanted to learn myself about T-cell lymphoma, just because it's very tricky and it's rare. This is not something that you would see as a hematologist. I wouldn't see on a daily basis. So it remains tricky. And I think the fact that the number of cases is small makes it harder to conduct clinical studies or even to develop personal experience or institutional experience. It's not an easy, straightforward. But I think some improvement is happening, especially with the introduction of targeted therapy. For example, CD30 positive cases, the outcome is improving dramatically, actually. But yet, there's some of, especially the ones that I didn't talk about, the hepatosplenic, for example, T-cell lymphoma, very aggressive, no regimen yet to proven to improve the outcome of these patients. I think yet
yeah. If I just may add, in the countries where T-cell lymphoma is very common, is it just related to the HTLV1 infection? And is it screening or treating HTLV1 infection is a possible modality in preventing T-cell lymphoma?
The infection, for example, with EBV or HTLV in endemic areas is very common. So, for example, CMV or EBV, out of 100 patients who get the infection, maybe 0.5% or 0.2% will develop lymphoma. So it's not only the viral epidemiology, it's the genetic predisposition, the multiple genetic insults that occur in the lymphoma stem cell. So it's not something, it wouldn't be cost effective to try to eliminate these viruses or screen the patients who test positive for these viruses in order to pick up lymphoma early, unfortunately.
Okay, thanks. If anybody would like to ask a question from the audience, I'm not sure how many hematologists we have. Maybe some more would be on the Facebook site, but from the participants, if anybody has a question. Anybody from the participants, or Dr. Lubna is around if she wants to ask a question herself. Right, I'm not sure whether Dr. Lubna is still with us, but right. Well, thanks again, actually, Dr. Khadija. One is glad to see some experts talking such high caliber language, in a very difficult topic. We will have your presentation on YouTube for others to view, and I'm sure some would find it very interesting to know about, especially the specialists dealing with lymphoma in Sudan. If no more comments from any of our audience, we just close the session.
I've been trying to see if there are comments on Facebook, but I couldn't. So
okay.
I guess yes, I guess this is the end of this marvelous session, and this is our first session in the triology. Well, inshallah, we will meet you in other sessions, inshallah. Thank you, Dr. Khadija. Thanks, Prof. Imad. On behalf of Tababa Advanced Training Center, we thank all the participants, and good night.
Right, good night. Thanks a lot for everybody who helped organizing this session, and thanks once again for Dr. Khadija. We hope to keep seeing you in our ATC sessions, right, enlightening us on these new modalities of treatment and new drugs. Right. Thank you very much.
السلام عليكم. مع السلامة.
شكرا جزيلا دكتور خديجة. شكرا جزيلا.